Hi, I'm Dr. Sanjay Naran. I serve as the ASPS University Dean of Pediatric and Craniofacial Surgery. I'm thrilled to introduce today's episode of Plastic Surgery Hot Seat, in which we'll be talking about craniofacial surgery, life outside of the OR. Medicine is not confined to the hospital, and it impacts people's lives in a significant way, some of which may not readily be appreciated by us in the hospital setting or even the postoperative setting when we see our patients in follow-up. To help us gain a better appreciation, we are fortunate to have Dr. Justine Lee and Dr. Kavitha Ranganathan provide their experience and perspective. I'll hand the microphone over to Dr. Lee to begin with an introduction of herself, and then we'll move on to Dr. Ranganathan.
Thanks, Sanjay. Thanks so much, Dr. Naran, for the invitation to be part of this really interesting podcast. It's definitely an interest of mine to talk about all the things related to craniofacial surgery that we don't always think about. My name is Justine Lee. I'm at UCLA. I'm a craniofacial surgeon there, and I do both pediatric craniofacial surgery as well as gender-affirming facial reconstruction. In addition to my job as a surgeon, we do quite a bit of outcomes research work in psychosocial outcomes in both populations.
Hi, this is Kavitha Ranganathan. It's such an honor to be here with both of you. I am a craniofacial surgeon at Brigham and Women's Hospital, where I do trauma reconstruction and cancer reconstruction for craniofacial patients. And I also do pediatric plastic surgery at Shriners Hospital for Children. My research is actually focused on why patients are becoming poor as a result of the surgeries that we're doing. And as part of that, this topic fits perfectly. So thank you for having me.
Great. Kavitha, can you tell us a little bit more about the research in regards to bankruptcy after surgery for some of the patients that you've been treating?
So it's an interesting problem because, while I started my career focused on global health, what I actually realized is that the problem of medical or healthcare-induced bankruptcy is actually a global one, and is actually, unfortunately, very prominent in the United States also. Worldwide, over 150 million patients struggle with the problem of being unable to afford healthcare or being able to afford very little after needing or receiving healthcare. And so that's a huge number. And the even bigger problem is that over 80 million patients struggle with surgery-induced bankruptcy, meaning that there are over 80 million people that need surgery that either can't afford it or can't afford anything else when they need surgery. So it's a huge problem that I think as plastic surgeons, we, I'm sure many of our patients deal with this, and I would love to solve this problem by the end of my career.
So just to clarify, though, we're talking about surgery that needs to be done. These are cases that are not really elective cosmetic cases. These are more reconstructive cases where patients are experiencing this hardship postoperatively and possibly a delay or inability to seek appropriate postoperative care because of those financial constraints.
That's a really interesting question. So to be honest, we don't actually know the answer to your question because so little is known on this topic. Based on modeling studies, though, that use estimates of how many people need surgery and what surgery generally costs, it could be patients that need elective surgery or patients that need non-elective surgery. Basically, any patient is at risk. And while we oftentimes think that it's actually poor patients or only patients that are on Medicaid that are at risk for poverty after needing healthcare of any sort, it's actually patients with private insurance that are just at high risk as well. And so really anyone could be a victim of healthcare-induced bankruptcy. It's just the cause of those expenses and cause of that poverty that can be variable.
Justine, has any of your experience been different for a primarily pediatric patient population? Usually many states have contingencies for medical care for pediatric patients that don't exist for adult patients.
Yeah, that's. I think Kavita's research is just so interesting and really kind of hits home for me, to be honest, because my own personal immigrant parents have the same fears about medical care in general. But to your question, Sanjay, the majority of our patients who are pediatric patients are 70% of them are covered under Medi-Cal, which is a California version of Medicaid, and so we typically don't have that type of issue in terms of bankruptcy, but they may have started from a very, very disadvantaged, economically disadvantaged place, meaning that the things that we're looking at for them is not so much the care afterwards, but even being able to afford transportation to get to the care, whatever the care may be, outpatient visits as well as inpatient surgical stays. I'd say that an interesting phenomenon that we had seen in our psychosocial work over and over again is, and we can't explain it, but we see this, is that our patients with private insurance have a tendency to report worse psychosocial outcomes compared to our patients with public insurance.
I think that's very interesting because one of my experiences, I'll just share one of my experiences in terms of medical cost. It was a pediatric patient and they had nasal trauma, documented history of an accident, a nasal bone fracture, a significant external deformed appearance, as well as nasal obstruction. All of this was documented in my note. We submitted it to the insurance company and submitted for prior authorization, the CPT code. And just like many times in the past, the insurance company approved the code. But as we all know, an insurance company saying, sure, the surgery is approved is not a guarantee that they're going to pay for it after the fact. So we went to the operating room fairly confident that, okay, the insurance company is going to pay for this. They're aware of the surgery. They're aware of the context of the surgery. And after the surgery was completed, the family received a bill for the entire cost of surgery. And the insurance company had said that they denied covering it, even though they previously had said it was an approved code. And I was really powerless to do anything for this family except talk to our hospital billing department and help the family convince the hospital that some of the charges should be dropped. So I was insistent that my surgeon fee be dropped, but I couldn't do anything to change the anesthesia fee and some of the facility fee. And so the family was still left with over a bill that was over $10,000. Have either of you had experiences like this for some of your patients?
I feel like I struggle with this on a daily basis, to be honest, and to the point that it's almost like a war of attrition when I'm dealing with insurance companies. And thankfully, my team just never gives up, and we keep hounding them. So most things we get covered, but certainly, especially for my gender-affirming surgery patients, which my approach is very inspired by Dr. Lee, actually, but especially for those cases, it takes hours and hours of effort to get anything approved. And even when we do get approved, it's very similar to you in that the patients unfortunately still get expenses that we have to deal with on the back end. And so it's definitely a challenge. It's hard to know what to do to address the problem, other than the fact that I do think that surgeons and physicians need to be more involved in the processes that go into the regulations around insurance companies and pharmaceutical companies and things like that. Because if we're not involved, we end up, putting in the work and continuing the process as it is. But in order to effectively advocate for our patients, we really need to go beyond what we're currently doing.
So Kavita, if I may ask a question, what do you, in terms of your research, what are you thinking of now? How are you looking into this? Are you focusing on any particular areas?
Yeah, so the reason why I picked this topic was because when I was thinking about my academic career, what I'm most excited about is global health, but at the same time, there's not necessarily a traditional model of academic success in global health. And so I wanted to pick a topic that spoke to my interest, but was also domestically relevant, in addition to being internationally relevant. And so an example of what we're doing now is we're doing a multi-center study in India where we are capturing data on trauma patients that have undergone surgery and the short-term and long-term costs and consequences of what it means to have surgery in the setting of trauma. So we have 500 patients from a government hospital, a private hospital, and kind of a value-based, quote unquote, value-based kind of hospital. And what we have found so far is that when we're thinking about why patients are having challenges both in the perioperative period and in the post-op period, I call it kind of the new two-hit hypothesis, two-hit hypothesis, in that patients are struggling initially because of how expensive care is, specifically related to the hospital bill that they receive. But somehow by 1 month after surgery, they're able to accommodate these costs, whether it's borrowing money from family members or selling their houses or selling their possessions or, doing whatever it takes to get through that initial period. But then once they recover, at 3 months, they suffer again. And now it's because of the disability associated with having trauma and the fact that people are unable to return back to their same jobs, or they're missing work more, or, a variety of different factors that then lead to patients being unable to afford food and housing and basic necessities like clothing. And so I call it the two-hit hypothesis because patients are struggling both initially with the cost of surgery, the quote unquote direct medical expenses, but even when they're able to afford that, the disability that is incurred is kind of the second hit. And that, I think, is what prevents patients from getting back on their feet. But also what is exciting about this topic is that if you intervene at any of those 2 points, my hypothesis is that you can potentially change the trajectory of people's lives in a way that, when you intervene on hypertension or, chronic medical problems, you don't necessarily have that same potential. But that it's still really early on. But that's kind of what's exciting to me about this idea so far.
Awesome.
So forgive me for asking a blunt question, but short of reducing charges and giving patients money, what sort of interventions can we do to help with that, help provide a solution to that? When I think of things like trying to reduce costs, I try to be conscious about the diagnostic tools, or ordering imaging and tests that aren't necessarily going to change my treatment plan. It's one thing to be academic and have some of these things, but if it's not really going to change what we're going to do, then I very much steer away from ordering those things. And that certainly helps reduce some costs, but what other interventions can we apply at those two different time points that would lead to a potentially better outcome for these patients?
Yeah, that's an interesting question that I've struggled with. So I have thought about this problem from a couple different perspectives. The first is reducing costs from an institutional standpoint. And that to me seems really hard, specifically because cost is not a transparent thing in our health system. And there are so many different factors, whether it's insurance companies or how expensive care is within a hospital, and frankly, the inability to get such data that has prevented me from trying to address it from that standpoint. So I've kind of focused on thinking about how patients can accommodate these costs, whether it's, financial planning or helping patients enroll in programs, or even advocating for increased SNAP benefits during the perioperative period, things like that are more at the patient level. So that's kind of the approach I've taken. But I think someone like Dr. Lee might have better perspective coming from a state that probably does have better policies for its patients in terms of being able to afford care, and whether it's job training programs or other programs that are kind of thinking outside of the box for what we can do at a policy level.
I wish I could say that we have much better options, but to be honest, I'm not sure that there are, I'm not sure that there are organized methods of being able to get through affording care. And I mean that, just as the observation that you had, that it's more for or private insurance patients, less so for or public insurance patients. And I think that that's definitely something that is challenging still. I have a couple of patients that they're families, so pediatric craniofacial patients, and they don't come to multidisciplinary clinic because it's too expensive, and they just kind of pick and choose and go to the specialties that they need to see when they need to see them.
Yeah, Sanjay, I have a couple other thoughts on that too, based on what Dr. Lee said. I think there are some tangible things that we as providers can do. The first is when you think about transportation, parking in the hospital is extremely expensive. So I think we as providers can advocate for our patients to get free parking when they come to Cleft Clinic or, whatever it might be. I think free parking, $40 a day is what it is in our hospital. And that's a lot of money. And when you think about the consequences of waiving that cost, I think that would be huge for some families. Another thing is similarly to what I'm sure all of our multidisciplinary clinics do is having patients come in for all of their visits at once. And so this is especially important for daily wage laborers who, if you have 5 appointments throughout the month, you can't really take 5 days off. And when a patient does miss an appointment, we are all, as a society, very quick to judge patients on why they may or may not show up. And perhaps it's just because people have a hard time missing work because then they can't afford to put food on the table or school for their kids or all of the other kind of more essential things that come with life other than having your surgeon tell you that you're doing fine. So, grouping those appointments into one sitting can help patients who, especially in the pediatric situation, parents who can't miss work, but still would like to get good care for their kids. And then my last suggestion is just that we as plastic surgeons, I think, have missed out on some opportunities that we could think about to change the trajectory of patients' lives. An example that I can give for that is one of my facial trauma patients, came from a lower socioeconomic status or economically disadvantaged background. And, he wanted to turn things around, but just couldn't for himself for the longest time. And every week I would save a spot for him in clinic, and sometimes he would show up, sometimes he wouldn't. But eventually, now, he owns his own company and is back on his feet and has recovered from a variety of different social issues that, he may not have. And it's hard to think about the fact that, a clinic visit or just a scheduled visit can change something, but perhaps it can. And we just have been, not thinking beyond the initial perioperative period for what happens to patients outside of surgery. That approach sometimes doesn't work. I also did that for an 18-year-old patient with mandible fracture that I just saved him a spot in my clinic every week in case he showed up with his grandmother. And, most of the time he didn't show up. And I'm sure he's still in a really challenging situation, but I think trying is really the best thing we can do, and kind of asking people about their circumstances when they do see us in clinic so that we can intervene both short and long term whenever it's possible.
I think those are great points. We all know that change, significant or meaningful change in this regard, is going to start with us. And little things like you had mentioned, parking is a big deal. I'm fortunate that at all of our hospitals there's no charge for parking, but some of the other hospitals here in Chicago charged significant amounts, more than $40 to park downtown. I think one of the other things that we should think about is in regards to taking time off work. It's not something I usually think about because I usually treat pediatric patients, but it's kind of similar because I think about their school hours. And so I try to arrange our clinic hours so that they're after school, so they can come in and not have to worry about missing school to come and see me. I think one of the other things that we do that takes into account the seeing multiple providers, even if it's not a true multidisciplinary clinic, is if they're coming in to see me or one of my colleagues, we will combine a video visit with that in-person visit. And that's really taken off since COVID, now that we're doing more and more video and virtual visits. So we'll leave our laptop or the computer in the room with the camera open so that they can have their visit with the pediatric neurosurgeon or one of the pediatric ear, nose, and throat doctor while they are there in the hospital with me. So that way, it reduces the number of times they have to come into the hospital. So I think those are all great points that all of us can try and implement in very short time.
I totally agree. And I think it would be interesting to see how patient-reported outcomes change as a result of that. We don't really know the data around that. But I know Dr. Lee has done a lot of work in this area, and I think it would be interesting to see if patient-reported outcomes do change when financial challenges become more or less evident in people's lives. Because oftentimes what we're studying is just the, change in appearance or change in function that comes with surgery. But I wonder if our outcome metrics need to actually expand to what's happening to patients outside of the OR too.
Yeah, I think that's a phenomenal point. Yeah, absolutely so. And I see that, I would say, the easiest patients that I see this in are actually the gender affirming facial reconstruction patients, because things like, for example, work changes, really fast life changes, all that tends to kind of show up in the psychosocial outcomes. But I think that both of your points in terms of thinking of different creative ways, it'd be interesting to even consider just going completely virtual for a routine annual multidisciplinary cleft and craniofacial appointment. It's very few things we actually absolutely need to physically see. And I wonder if we can just coordinate care that way.
That's such an interesting idea, because I think that would cut down so much cost. I'm personally technologically challenged, so some patients might have a tough time with that. But I think for the patients that are tech savvy, I think that would be wonderful. And I think even in many lower income families, people are still using cell phones and smartphones, and I think in the elderly population, it would be potentially more challenging to do virtual visits. But in the pediatric population, I think the younger generations certainly are more tech savvy, even than I am, for sure. So I think that would be a great idea.
Kavitha, I wanted to go back to something that you'd mentioned earlier. This is not just a domestic issue. This is a global health issue. But all too often, when we think about medicine here in the U.S., we're reminded of how expensive it is and how inefficient it is compared to other countries. What were some of the other countries' report cards? Were there other countries that fared far worse in terms of a greater percentage of patients having these significant financial and social difficulties following surgery after trauma? Were other countries did other countries have a much better report card? Were there any indications as to what they may have been doing differently apart from having completely free healthcare?
I think that the healthcare in the U.S., as you mentioned, is extremely expensive, and the outcomes don't match in a proportionate way to how high the cost is. One of the hospitals that I do research at in India, called Ganga Hospital, that's run by Dr. Sabapathy, who's part of the AAPS, actually, they, I think, serve as an amazing example of the balance between cost and outcomes. Their motto is actually 99% success is a failure, if that tells you anything about how they're run. But I'll tell you a story that kind of highlights why I think the US is not actually picture perfect or, even an example for what people should do. As both of you do, we receive lots of emails for international patients that, potentially have complications from other surgeries or whatever it might be. And I received an email from a mother that was really concerned about her son who had surgery elsewhere in the United States, and over the past couple of years had been developing complications. And unfortunately, no center in the US was willing to take care of them, because I think every center has kind of cut down on the opportunities for international patients just because of costs and the recovery that hospitals have had to make after COVID. And I actually was able to find a hospital in India that was able to care for the patient. And while surgery at a US hospital would have been over $100,000, including ICU stay and the surgical supplies and imaging and everything like that, surgery was able to be done in India for $2,000. So $100,000 versus $2,000 for the same operation, and that the surgery team conducted with extreme excellence internationally. I think that's an example of why surgical care in the United States is not sustainable in the least bit, not only for international patients but for domestic patients too. And as we as a group are thinking about needs of international patients, perhaps it's time to think about international patients seeking care in low and middle income countries that do have the skills and expertise to get care done in a more cost-effective manner compared to what we can in the US. That relates to multiple different themes, including our general underestimation of what others in countries across the world are able to do. But I think is something that we as plastic surgeons really have to challenge ourselves on.
I think that's a great example of a place that's really doing a lot to address this and be really conscious about how they're providing care to patients, the impact of that care on those patients, and trying to optimize that postoperative outcome. I really like the motto, 99% success is a failure. So I think that if there's an opportunity to be better in that way here, all of us want to do that. It's difficult when you're one doctor in a big machine that is a massive hospital system. Sometimes you feel a little irrelevant and it's hard to move the needle, but incremental changes eventually add up. So we've mentioned several different things that we can all do starting tomorrow to help make this experience, because oftentimes in cases of trauma, or all the time, it's not a good experience to begin with, but we can ease some of that additional social and financial pain for our patients by implementing some of the things that we've talked about already. One of the things that we have in terms of resources, I know for our cleft craniofacial patients, are social service networks. So we have a social worker who's familiar with a lot of the community resources that are specifically available to cleft patients. But we don't always have adult patients see social workers as part of their complex care, at least not at our hospital. Is that something that either of you guys do? Because I think for a patient that's come in as a trauma or a cancer patient that's seeing multiple providers, has multiple tests, multiple surgeries, a long list of follow-up, people need help to organize all of these things. And us as individuals, or the limited resources within each of our offices, may not be enough to accommodate that need.
Yeah, I agree with you, Sanjay. That's one of the things with adults maybe that we're not quite as good about. I would say that, the only adults pretty much that I work on are adults who are transgender and going through gender affirming care. I will say that in a number of the gender affirming healthcare teams, there are social workers that are frequently around to kind of help out. Like, for example, we work with LA LGBT a lot, as well as our own, home gender health program. And there are definitely some social workers who can kind of bring resources, or at least help patients find resources for some income related things, as well as just general, issues with support?
I struggle with social work all the time. There are a lot of patients that I try to have see social work, especially, for example, undocumented immigrants or, my trauma patients. I do try really hard to have them see social workers. I think it goes back to what you were saying also, Sanjay, in terms of, sometimes in very large academic institutions, it's hard to kind of feel empowered to do what you have to do for patients. And sometimes the resources for certain things just aren't there. And that's what I find really, challenging sometimes, is that you have this opportunity to really change someone's life, whether it's non-operative or operative management. But outside of the surgical plan, you have an opportunity to really change someone's life. And sometimes you're just limited by the resources that you have. So my administrative assistant has kind of become a social worker also. I think my PA has also become a social worker during the time since I started at the Brigham. So we're trying to be creative, but I think it's one of the biggest challenges that I face for my patients that are really in need.
I think the last question I had is going back to how we affect this change. And one of the things that you had mentioned, Kavitha, earlier is having a seat at the table. So what are some of the resources or groups within, not only within ASPS, but within hospital systems that you would recommend becoming more involved in? So, for example, at our hospital, we have a patient satisfaction committee that when we meet every month, and we basically go over the most extreme complaints from patients when we look at their feedback and try to find opportunities to improve upon that. And some of them touch upon what you had mentioned in terms of unexpected costs that were associated with a visit. What are some of the other things that we can do to have, at which tables should we be pulling a seat up to in order to try and do better for our patients?
I think we need to be expanding outside of the world of medicine and surgery. And I say that because while it's possible to enact change in our own institutions, sometimes I feel like one of the biggest flaws in medicine is that we are almost just too immersed in medicine. And when you think about who's actually affecting change on insurance companies and pharmaceutical companies and access to care and coverage and cost, all these massive issues, it's actually senators and House of Representatives members and these higher up political organizations that are actually completely outside of medicine. So I haven't figured out any of these organizations outside of medicine, but I do think that is an area that we've traditionally lacked in terms of our involvement, and I think would be the best kind of bang for our buck. Because if we think of institutions within the hospital alone, I think that is fitting more within the traditional silo that we've always been in. And it's really hard to regulate things even within the hospital. But perhaps if we get out of our comfort zone and reach out to other organizations outside of medicine, sometimes I think that might be even more effective.
Yeah, I think I can't possibly agree with Kavitha more. That is one of the problems with being a physician and being a plastic surgeon is we love being physicians and plastic surgeons, and that makes everything else seem less interesting. But at the same time, there are certain limits to how far we can go for patients, and sometimes going bigger and coming outside of medicine might be the way to be. In terms of like any other thoughts on this in this general arena, I mean, I think that probably one of the other things that we could do outside of clinical care is gather as much data as we can to support any of our colleagues, or as Kavitha said, senators, so to speak, with really arm them with the data of what's happening at the ground level for our patients. And I think that can be very powerful too. So yeah, I think it's super interesting to see Kavita's research in bankruptcy. I think the fact that we're looking at how people are doing, their well-being, their quality of life, their psychosocial outcomes, secondary to their medical care and plastic surgical care, reconstructive surgical care, I think are all pieces of evidence that can really contribute to helping our patients in the long run.
Well, thank you guys both. Thank you, Dr. Lee, Dr. Ranganathan, for a really great conversation on a topic that I think many of us don't pay enough attention to. We've ended this conversation with a lot of great ideas in terms of how we can actually affect change starting tomorrow. It starts with us, and we do have resources. They're there, and we just need to look a little bit harder for them. But having a better appreciation for life outside of the operating room for our patients, at the end of the day, not only is it going to help our patients a lot more, but it's going to help us be better doctors. So a special thank you to both of you for this conversation. Thank you to our listeners. We hope you enjoyed the podcast. And thank you again for listening to Plastic Surgery Hot Seat. And be sure to be on the lookout for the next episode.
Thank you so much for the opportunity. It was wonderful to be here with you both.